introduce today's speaker. So I'm delighted to introduce my friend and colleague, Professor Clement Adebamowo from the University of Maryland. Clement is someone I've known for about 10 years now, I suppose, through our mutual work and collective work in conducting and directing COVID bioethics training programs. Clement has run training programs in Nigeria now for at least a decade, if not more, in bioethics, with support from the NIH, COVID International Center. And through that initiative, has established a Center for Bioethics at the University of Baden, and has trained countless individuals at the master's level and at other levels as well, over 50 individuals at the master's level in Nigeria. It's made a tremendous impact in bioethics training, capacity strengthening in West Africa in particular. And so I think I lead with that because I think that's a big part of the contribution globally to training capacity. Clement is also a professor in the Department of Epidemiology at the School of Public Health, in Public Health, and Associate Director of the Population Science Program. You can see he has a lot of titles, so reflective, I think, of the various things he does in public health, in genetics and genomics research, in clinical care, and has a lot of responsibilities in all of those areas. He's the PI of a number of different projects, including genomic studies. And he's going to share an interesting study that he's conducted recently on communicating about genomics and genetics in different parts of Nigeria. And so you can see his title, and I'll just welcome Clement. Thank you so much for joining us today.
Thank you. Thank you very much for inviting me. It's always a pleasure to hang out with Joe and Nancy and all the other wonderful people at the Institute and Johns Hopkins. And as Joe mentioned, we've been interacting for several years. And the bioethics training community is really one of those communities that I'm extremely proud to be a member of, very mutually supportive and cognizant of the fact that we're all trying to, in some little way, make the world a little bit better than we meant it. So today I'm going to share with you some thoughts and hopefully learn also from you a lot more than I'm going to be talking about on issues related to comprehension of informed consent. Now, informed consent and its implementation is the foundational issue in research ethics, right? So a lot of what we're engaged in is thinking about the basis of it, the moral philosophical foundations of it, the legal authorities and things like that. And all these wonderful people who do a great job of doing that. I am more on the, you can think of me as an implementation scientist for research ethics. Okay. So you're going to get that perspective. I'm going to also share with you some of the work that we have done, which I think is not very well known, but it would be nice to share with this. So, am I doing this? Is Jimmy here? Yeah, it's Jimmy. Yeah. So into this research ethics journey and some of the things I've been involved in, and then segue into the work that we have done and what we're currently doing as our contribution to the field. So my background is I'm a physician. I studied in Nigeria and then went on to do surgical oncology and renal transplantation. And started to do research on the epidemiology primarily of breast cancer, but also of other cancers in the 90s. And from there moved on as the BRCA story emerged to collaborating with people including Fumio at the University of Chicago on search for, at that time, what we thought might be a BRCA3 gene in the African population, because we thought the epidemiology of breast cancer in that population suggests that most of the cases might have a genetic origin, and studying that population might yield that information. Some of the rationale for that, or those studies that we did, have been overtaken by what we now know in genetic epidemiology. So at that time, anytime we go talk about our work, we're always kind of challenged by scientists who are concerned about whether the individuals that were enrolling in our studies fully comprehend what they are participating in. And as a physician, and this is an important concern, and we didn't want to dismiss it. So along the way, I started to work with Patricia Marshall at Case Western. She came to Nigeria as part of the President's Bioethics Committee to look at cultural relativism in international genomics research and worked with me at that time. And from our interaction, this led to her submission of an R1 grant application, which was funded, and part of what I'll discuss the results from that study, from that grant. And then things moved on. We worked with the NIH in the days when the NIH wanted to build the molecular biology foundation for what we now call genome-wide association studies. So those in that field will know that the International Haplotype Mapping Project was the foundational database upon which modern GWAS studies are built. So I was PI for the Nigerian site, and again, as many who were part of that initiative will testify, there was a lot of ethical issues about comprehension, about return of results, about what you share with the community. So we were in the midst of all that. And then Patty, having completed her first R1, submitted a continuation R1, this time designing a randomized trial of an educational intervention to see whether that intervention improves comprehension of informed consent documents and improves participation in ethics, in research. In between all that, I came to the US and earned a doctorate in epidemiology and biostatistics, then returned to Nigeria to continue working. So that's my training and background. Now, in 2005, we started receiving funds from the NIH to implement research ethics education program in Nigeria. And since then, we have developed a multidisciplinary master's degree in research ethics, and we've trained 52 individuals at master's level to date. For several reasons, I resisted taking on doctoral students into the program, but a year ago, kind of relented, and we have a PhD student in the program. But some of the other trainees have gone on to other institutions to earn their doctorate. So that is working out pretty well. The other major thing that we do is linked to the next slide, but I'll talk about it now. And that is we provide access to the CITI online training for biomedical researchers in Nigeria through our web portal. So individual institutions don't have to set this up and pay for it, but by getting everybody to go through our portal and we pay CITI, we kind of massively opened this opportunity to biomedical investigators in Nigeria. And to date, I think close to 30,000 people have taken those trainings through our portal. Now, realizing that the CITI training is largely introductory, and a lot of the people who are sitting on ethics committees in Nigeria and other parts of Africa don't have the time to go away to do a master's program or any more advanced training. We developed what we call a blended diploma, which lasts about 3 months, consists of about 8 weeks of online work and 3 weekend retreats, during which participants interact with faculty and have questions answered, and then we administer evaluations. So this is also working out well, and it provides a higher level of training than the CITI, particularly to members of institutional ethics committees. So this year, we are now setting up a standalone Department of Bioethics in the University of Ibadan. This has some roots in how graduate education is implemented in many parts of Sub-Saharan Africa. I won't bore you with that, but it really is, a very significant milestone that we have a Department of Bioethics. And then we're setting up a master's degree program in bioethics at a university in eastern Nigeria. For those who do not know, Nigeria has a population of about 200 million people and speak about 500 different languages, but English is the official language. And some of you may be aware of the controversy with the Oscars committee saying that Nigeria submitted a film in English language. Oh my God. That's our language. It's a different English than American English, right? And there are books on so-called Englishes that kind of highlight the fact that there are all these different types of English language spoken throughout the world. So I guess the Oscar committee should have considered this a film submitted in Nigerian English. And that's a foreign language to Americans. Okay. All right, so, but we're also setting up a different type of bioethics training in the rationale for that, in which the individuals actually earn an MPH and then do additional training to earn a certificate in bioethics. So I said we had this opportunity to provide CITI training through our portal for biomedical investigators in Nigeria. And that's because of an early connection between my work and in providing training and in also helping the country to establish a research ethics regulatory environment. So that led to the establishment of a National Health Research Ethics Committee in 2006, and I became chair of that, was chair till 2017. This committee is the equivalent of OHRP, except that it has a little bit more power, a little bit more oversight function, and is more integrated with the institutional ethics committees. It regulates them, it categorizes them, it serves as a referral for disputes that may emanate from institutional reviews and things like that. So that NREC, we'll call it, generated and developed a guideline for research in Nigeria, which in many instances anticipated some of the changes that the US guideline is now introducing, including central IRB. And I've, over the years, either established or re-established over 50 institutional research ethics committees. So I continue to write guidelines, support the National Ethics Committee as they continue to grow. I'm no longer a chair. And I recently received funding from the European Union through this EDCTP program to introduce electronic IRB into Nigeria and get the Nigerian Drug Regulatory Agency and the National Ethics Committee to work better together in providing oversight for clinical trials in the country. So I think that's all about my background. These are my current funding. So we all agreed about the value of comprehension in research ethics. What we have not paid enough attention to, and if you're looking at the recent American Journal of Bioethics and all the discussion following on the report, that, hey, people do not seem to understand the consent that they're given when they're participating in biobank-based research, is that we really have not given as much attention to what it means to comprehend informed consent, and what are the parameters that determine this comprehension. So we agree that participants must comprehend the information. But what happens when you are enrolling participants in a study of vaginal microbiome like I did? I mean, so you look at the US, 5 years ago, 10 years ago, if you go out and you're enrolling people into a study of the microbiome, most do not know what that is. But if you watch TV, Dove now has an advert on TV talking about how their soap is good for your microbiome. So that is how knowledge of the microbiome is going to percolate into the community. And people will all of a sudden know that they know about microbiome without necessarily having received any specific training, okay? Now, so what about in low, middle income countries where, well, there's no doubt about that? So we know certain factors influence comprehension, age, educational status, reading ability, cognitive ability, and the fact that there is an oversight of the research, which makes the researchers pay more attention to ensuring that their participants understand the concept. And in the literature, there have been previous studies, not a lot, not as much as one would like, on how to ensure that participants do comprehend. And like I alluded to, discussions in the American Journal of Bioethics, this is not a low middle income country issue. It is a general issue. Are we sure that our research participants comprehend? And as part of our discussions today, the questions I will be asking you are, what does it matter? What are the things that we think is important for them to comprehend? And as you'll see in some of the work that we have done, comprehend for how long? I mean, you enroll in a genetic epidemiology study like the HAPMAP in the year 2000. This is 2019. If we come to you and we say, you enrolled in this study at so and so time, do you recall or did you understand that in giving your sample at that time, this are the implications, or this is what that meant? If the person doesn't recall, what does that mean? What's the implication of that? What's the responsibility that the researchers had and perhaps currently have in that situation? And what are the responsibilities of the research participants, the ethics committees, and the regulatory agencies? So there are many methods that are prescribed, recommended for improving research ethics. And this morning, for example, I was on a conference call. Some of you may be aware of the H3 Africa Consortium. The H3 Africa Consortium is a research consortium funded now to the tune of maybe $200 million by the NIH and the Wellcome Trust to do genomic research in Africa, provide training, build resources, biobanks, and bioinformatics, and also provide training. Okay? So within our consortium, within this H3 consortium, has arisen some concern that at the time some people were enrolled in these studies starting from 2013, they did not understand the meaning of commercialization. And now that data is being generated, and there's some debate about some actions of some researchers in Sanger Institute in the UK, working with Affymetrix to commercialize or develop a chip which is selling, people are now revising their comments and expectations about what was included in some of the consent forms in the H3 Africa project. So the big debate is, should we then go back and reconsent to make sure that people understand the potential for commercialization and things like that? So this comprehension issue is probably now going to become more of an issue than it had been in the past. All right. So in 2001, we worked with Paddy Marshall, Charles Rotimi, Deborah Adebamowo, and Richard Cooper at Loyola University in Chicago to do a mixed method study of individuals who had been enrolled in a genetic epidemiology study of hypertension in a rural area in Nigeria, in Jamaica, and in Maywood neighborhood in Chicago. So these individuals had been, they had participated in the study on the average, I'll show the length of this, but more than a year before we went back in to do this research ethics project. And what we did was to randomly select 10% of the participants and went back to ask them about how well they comprehended the informed consent at the time that they participated in the study. So briefly, the informed consent for the Nigerian site was written in English, translated to the local language, and back translated. Of course, the US consent did not need to go through that. And we didn't continue this study at the Jamaica site for several reasons. But we concluded that the consent form in the US and Nigeria was similar, and so there's no significant difference there. Okay. So overall, we have 655 participants in the study, 348 from the United States, 307 from Nigeria. And in the US, we had almost similar number of men and women, whereas in Nigeria there were more men than women. In the US, 84% of the participants identified as Christians. In Nigeria, it was more like 50-50. So the interval, and this is important, between the time that these individuals gave consent to participate in the genetic epidemiology of hypertension study and the time that we went in was longer for the participants in Nigeria than for those in the US. And this time interval for the US was 424 days for cases, people with hypertension, and 48 days for control. So it's quite a lot of time difference there. So we asked the respondents if they had been told the purpose of the study at the time that they participated. Most of the respondents in the US reported that they had been told, and 72% of the respondents in Nigeria said they had been told. But importantly is that 13% of the respondents in Nigeria were quite emphatic that they were not told the purpose of the study, and 15% could not remember. So we moved on and studied a different disease, this time breast cancer. So at that time, we were implementing an NIH-funded case control study of breast cancer in Nigeria. And so we used mixed methods to study 215 patients and control. This time, the time interval between our study and when the participants gave consent for the genetic epidemiology study was just a couple of days, maximum 3 weeks. In this study, most of the participants were able to read the consent form themselves rather than have it read to them. And all the participants that were interviewed reported that they were told about the purpose of the study, okay, in contrast with the hypertension participants. Then we asked them to describe in their own words the goals of the research, okay, to really evaluate whether they actually comprehended what they were told. And 70% said the purpose was to learn about genetic inheritance of breast cancer, while 30% said it was to learn about prevention and treatment of breast cancer. The breast cancer cases were more likely than the controls to say that this was a study of genetic inheritance. And here are some of the comments from the participants during our focus group discussion. So clearly, in contrast to the patients, the hypertension study, it looked like the breast cancer patients who were interviewed shortly after they participated in the study had a good comprehension of the informed consent and what they were participating in. So we came to a couple of conclusions. One, of course, educational level is important. We saw that in both the hypertensives and the breast cancer patients. I missed this up. But in contrast to the breast cancer patients, only 39% of the people in the US and 41% of those in Nigeria who were involved in the epidemiology of breast cancer study said the purpose was to learn about the genetic basis of hypertension. When we adjusted for the time, remember I showed you that the time interval between the US and Nigeria was significantly different. When we adjusted for that, we did not see any difference in the level of comprehension exhibited by participants in Nigeria versus the US. So we concluded that the skill of the research staff in obtaining informed consent is critical. It's something you really need to build up if you want to guarantee that the highest proportion of your participants will report that they comprehended the informed consent. We thought that disease type may also be important. I mean, breast cancer and cancers in general tend to really focus in contrast to hypertension, well-known, high-prevalent disease, and many people know that it's chronic, you can manage it, and outcomes are relatively good. In contrast with breast cancer in low middle-income countries, where close to 80% of patients die within 2 years of diagnosis. So that will concentrate anybody's mind. We also thought that the question here really is one of durability of comprehension. So in the hypertension case, the time interval was quite significant between when we took consent and when we went back, compared to the breast cancer patients. So we suggested that there is need to modify consent forms and focus more on brevity and clarity than using excessively long consent and engage in information dumping. We thought the simplified consent forms that use clear and linguistically relevant terms would be way better, and that when the potential risks of a study are high and you really cannot be certain that participants comprehend the consent, then perhaps you shouldn't do that study in that community. So in the last several years, we've taken these ideas forward. funded now by the NHGRI, we instituted a study we call INDIGE, which is Indigenous and Linguistics and Cultural Concepts of Genomics in Indigenous Populations in Africa. And the idea here is to go into the community and ask about the words and proverbs and adages and terms that they use when they want to communicate heritability issues, okay? Particularly in communities where there's already awareness of truly heritable diseases like sickle cell disease. So how do you explain that? How do you talk about that? Then, having learned those words, we wanted to incorporate them into a modified consent form and do a randomized trial of those modified consent forms. So we started with a qualitative study, different groups of people, and we did 12 focus groups of 10 participants each. And these are some of the focus group discussions. So we really went into the, all countries have downtowns and built-up areas and nice where you find, well-informed people. But we wanted to go to where the educational level is low and people might truly be challenged by the concepts that are discussed when we're talking about genetic epidemiology. And then we had a separate session for Muslims versus Christians because we can discuss that in some detail. So then we did KII as we engage the community. The communities identify community key opinion leaders who will engage, including herbalists and traditional medical doctors. And we studied them where they work. So we analyzed in standard qualitative research methods. And what we found was most of the respondents agreed that there are words and terminologies and programs that they use to communicate these ideas. And they gave us several examples of that. They also wanted us to know that this is something that's part of their culture and their history. For example, in their community in the past, before marriages are contracted, they will appoint an individual who will go and investigate the family history of the potential partner to look for heritable disorders that may manifest if these people marry. And so clearly they understand that, conditions are heritable and influenced by certain biological factors. They may not call those factors gene or SNPs, but they do not lack an awareness of their existence. Interestingly, they also seem to be aware that certain diseases are sex-linked, and they also had an understanding that some diseases can skip generations because, the way they put it is that trait may not be strong enough in certain individuals, but when they mix with others who may also carry weak versions of those traits, then the full problem comes up. And of course, sickle cell disease is a very good example of that. So they are aware of that. So they said, one blood could be stronger than the other, blah, blah, blah. So we put all of this together, and one of the things we learned in trying to use all of the wisdom that they shared with us is it's not so much the words, but rather the concepts. So in developing new informed consent form, it didn't really help when we put local words, intermix this with the English language. I'm sure you've read African literature, you see that kind of way of presenting information. But that didn't help. What helped was to describe in the way they understand it, these ideas and concepts. So we took that forward and said, look, other people, this is a common problem. So we decided to create an online database of the concepts and proverbs and sayings of the different tribes. And we invited researchers to kind of come in and contribute to this database. So that's an ongoing activity. That's the database with the words in the local language and the English translation. And so far, we have a fairly comprehensive database of 5 languages spoken in 11 countries. And my colleagues continue to work. We continue to work on putting all of this together. And now we are doing a randomized trial where participants in a breast cancer genetic epidemiology study are exposed to either the enhanced informed consent that's built on what we learned from this study, or the standard informed consent that the researchers themselves previously generated. So we hope that we're going to learn something and hopefully be able to improve the comprehension of informed consent going forward. Thank you very much.
Thanks so much, Clement. Wonderful talk, sharing long sort of history and trajectory of your work in this area. Just see if there are questions. Audience, Deborah's. While you're getting over there, I'll maybe just ask a quick one. You mentioned about 500 languages in Nigeria. How does that practically work with research in general, and particularly with genomics research? Can you use that?
Thank you. That's a good question, because that again fits into another of the things that we work on. So it's not unusual for international ethics committees and international researchers to say you should prepare your data collection tools, your informed consent documents in the local languages. Now, having chaired the National Ethics Committee, we usually recommend to researchers, one, most individuals, if you prepare it in the local language, I assume that your intention is that the research participant will read it in that language, right? But most individuals in Nigeria who can read their native language can also read English. And those who cannot read their native language cannot read English. So preparing the informed consent document in any one of the 500 languages, while it might assuage one's conscience that you've done something, you really haven't. It really doesn't. So what we recommend is prepare your good quality informed consent. If somebody comes along who does not or cannot read the language, let it be translated to the person in the presence of a witness. Okay, that I think is more truthful and more valuable than imposing, as I think is the basis for your question, a demand that go prepare consent in how many languages? 10, 15, and then the person who speaks the 16th language will then turn up, and then you're really screwed.
Thanks. Deborah.
Deborah Matthews, thank you so much. That was really interesting. Here in the US, of course, our IRB system is incredibly diverse and incredibly inconsistent, right? So there's been a huge amount of research on informed consent, but getting best practices actually enacted and implemented is difficult. What are the processes available to you there to, as you're doing your research and developing best practices, to let those best practices, or enable those best practices to permeate throughout the system?
So there are several things that we do. One is, training. We require members of ethics committees to undergo training every year. And we require the chairperson and the administrator to attend a meeting called Forum of National Ethics Committees. So at that meeting, people share best practices, they ask questions, they learn from each other. Now we're in the process of implementing using Zoom for all the ethics committees in the country to meet once a month. Okay. So we recognize this problem, and I will be the first to tell you that there is a lot of inconsistency in the application of the rules, and we think that having a referral system, I didn't describe that in detail, but it's really multi-layered, in which one ethics committee can actually say, we don't think we're doing a good job with this review. We know, so the categories A, B, C, D, we're category C ethics committee. We're going to refer this protocol to a category B ethics committee. And if they feel that that doesn't solve the problem, we're going to refer this to the National Ethics Committee. But in the same way, a researcher can take that initiative and say, I think my protocol is going to be challenging for the ethics committee in my institution. I'm going to go to the national and see what they will say. So the national committee may say, you're right, we'll review, and then send the report to your institution. Or they may say, oh, we know your institutional ethics committee, they can deal with it.
And the national committee review is considered binding?
It's binding.
Yeah.
It's nationally binding.
Yep. That's great. That's really interesting. Thank you.
Other questions?
Thank you so much for this. In incorporating local indigenous concepts, as you said, for genes and heritability, I imagine there's a danger in conflating biases or beliefs about those things with what you're trying to get consent for. So there could be perhaps a history of the use of that term that splits cultures or creates new frictions. I was wondering, how do you navigate those complicated waters with culture interacting with language when you're using a local term?
Thank you. Great question. So far, we have not faced that challenge, but we do consider that it's a potential problem. Now, everybody who works in this field will say that all of these things are living documents subject to continuing growth and revisions. So we expect that at some point we're going to have to deal with some of these issues. But what I think is the most important that we are doing is we're putting the infrastructure in place to be able to respond to those problems when they arise.
Hi, thank you. Brian. Thank you for the talk, it was very interesting. I would just like to hear more about the way in which different religious beliefs impacted your research, as you sort of hinted at.
Yeah.
Okay. So all religions have some general basic principles. If you're a Christian, you have a certain idea of the role of Jesus Christ, but at different local levels, different communities, those ideas are not necessarily the same. Okay? So in Nigeria, whether within the Christian community or the Muslims, we see significant variation in beliefs and understanding. This is particularly challenging with the Muslim community, where because of the history and the practice of the religion, there is less public education about health. So you then find that when an ethics committee reviews an informed consent document, which may work for a predominantly Christian community, it does not work at all for Muslims living in the same city, on the same streets. Because, see, the Christian groups tend to have health fairs, mothers of the church, Sunday activity, health talks. But Islam doesn't work that way. So it's really huge differences.
Thank you.
Thank you very much. Another question, sort of in the spirit of culture-related questions. I'm sorry, our colleague Joe Carice isn't here. Joe did a seminal ethnography of informed consent in the indigenous population. In his case, it was Native Americans in this country. And one of the things he found was that there was a real resistance to talking about anything related to risk, because there was some, superstition is probably not the right word, but there was the sense that if you talked about risk, you might actually make whatever it is you're talking about happen. So I'm wondering if you came across, comprehension is partly about understanding, it's also partly about sort of willingness to engage in a discussion of concepts that you may be very resistant to talking about. Did you find that?
That's a great question, and I'm sorry I missed this person. Who have been great to hear more about his. The fact is, in most sub-Saharan Africa today, people are living multiple lives, if you want to think about it that way. For example, somebody might meet me outside a clinic, and I say, oh, how are you doing? And the person says, oh, great, I thank God, Jesus is working wonders in my life. Then the same individual will both walk into the clinic, and I sit down in my role now as a physician, and the person is now in the role of a patient. The person says, oh, my life is crappy. I mean, it's going down the toilet. I don't know what's happening. People live these multiple lives. And within, so it depends on which role they are playing when we enroll them in our research projects. And that is the persona that we're enrolling. And I believe that's one of the reasons you find that in the breast cancer study, they were paying attention. But many of those same individuals outside of the clinic will say, no, breast cancer is not their portion. That's the common term that's used. Because, everything's been taken away. I don't remember the details, but there are some biblical words that people use to deny. So they're living these different personalities.
This is a little bit more of, I guess, an extension of Gail's point. I was thinking to the degree that you would comment on how trust impacts comprehension. We talk about education and familiarity, and even with the language and the lingo of research and so forth, but how does trust figure into, first of all, whether people join or whether they decline?
Thank you. Great question. So on one of the slides, I highlighted the proportion of people who join the study and those who decline. In most situations, we're talking somewhere north of 90% when you ask people to participate. And there's no question that a lot of that is because of trust in the institutions and in the physicians. But as you know, the reason why, I think one of the reasons why trust doesn't occupy such a front and center position in the theory of informed consent and in the practice is because it's so difficult to measure, right? So because we can't, and it's easier to say, sign here because you've understood what, beneficence and all of that stuff, but trust. So it's really an important part, and in most situations in our country, I think people join research projects because they trust the institutions and the people who are offering the studies.
Thanks so much for an illuminating talk. In the article that you sent around to some of the fellows, you were talking about the breast cancer study and how informed consent for the women involved in some instances talking with their husbands to get permission. And I'm wondering if you noticed any other gender differences in how informed consent was occurring, or maybe in some of the concepts that you were uncovering with regards to genetics.
Thank you. There's a lot of gender roles and issues related to the power and relationships that influence what we see when we invite individuals to participate. But it's, we're from time to time surprised by how it plays out. What I've learned from interacting with this largely urban and semi-urban population, which is where most patients with breast cancer come from, is the women over the years have become increasingly empowered. So the paradigmatic example that I saw was a Muslim woman covered head to toe in hijab, 30-something years old, with breast cancer. And because of our own biases in terms of what we think goes on in Muslim homes where the woman wears a hijab, we told her we would like to discuss her diagnosis in the presence of her husband. So she said, okay, and she brought the husband in. And so, we said, okay, this is what we want to talk about. You have breast cancer, it's advanced. And then the woman took one look at me and said, are you crazy? Is that why you asked me to bring this useless fellow? As soon as I die, he's going to marry somebody else. Even as I leave, he's going to marry somebody else. So this is my decision. That took us a little bit by surprise, because that's not what we usually think. And even in some Christian partners that we have seen, that's not how. So there's no one single way in which these things express themselves. I've seen, wives of professors who were upset that we did not wait for the husband before we discussed diagnosis. And so it's really a very complex situation. It cannot be described very simply, I'm afraid.
I wonder, Clement, is it similar for when we think about individual consent? I mean, I think much of what you shared today is based on an understanding that, right, we seek consent from those individuals and we have to maximize our ability to do that. But there's a lot of discussion also, as you know, around sort of community consent and collective forms of consent, or at least disclosure of things. Did that come into any of your studies?
It did, particularly with the HapMap study, but I've kind of focused on non-communicable diseases, which tend to lend themselves more to this principalist approach to research ethics. In studies, for example, of trying to eliminate a guinea worm in a community, or in the HapMap study where we were enrolling trios in the community, and these trios had no health conditions at all. we certainly had to, and you will have to negotiate community entry and approval. In some of those situations, based on the structure of the community, if you don't get approval, you can't enroll people in the community. But there have also been instances where the local head of the community said, I don't approve, and individual members say, good for you, we're going to participate in this study. So there, also, and you may be following the story about the Greenebaum elimination that President Carter has devoted quite a lot of years of his life, and how many communities resisted revealing sources of contaminated water supply because those water sources were linked to spiritual and cultural practices, even after they've been educated by all the agencies that, this is how this infection is transmitted. If somebody is infected in your community, jumps inside the water, and you guys jump in to honor your God, then your God is transmitting Greenebaum. So these issues are complex.
Questions, comments? So I should have mentioned this seminar is co-sponsored by the IRB, School of Public Health and School of Medicine. So Jamie and I remembered. Yeah. Well, thanks very much to our speaker, Dr. Adebamowo, for joining us today, and thank you all for joining as well.